Good afternoon, everyone. My name's Mike Healy. Welcome to this session on the recognition, assessment and management of acute sports-related concussion. What I intend to do during the short session that we've got is lay down a foundation on the principles of recognition, assessment and management of acute concussion. Principles which will underpin your knowledge and understanding. And what I'm also going to address at the end of the session are a few matters in terms of clinical governance. Now, as practitioners, one of your obligations is to ensure that player welfare comes first. You should not be managing athletes or players on the basis of sporting outcomes. Equally, you should be evaluating and treating the concussed player and observing current established guidelines, and also aim to improve player health and safety to prevent the short and long-term adverse consequences following concussion. Now, if you're not familiar with this particular group, the Concussion in Sport group, then you should be, because these are the world-leading experts in sport-related concussion. They're representatives from the IOC, FIFA, the NFL, the National Hockey League, rugby, ice hockey, equestrianism, and Aussie rules football. And this group meets on a 4-yearly basis, or at least they did do until COVID interrupted last year's planned conference. But they meet on a regular basis and they create a consensus-based approach on the principles and conceptual understanding of concussion. They produce contemporaneous guidance, which again is then communicated to sporting organisations to ensure best practice takes place. The next conference is planned to be for Paris in 2021. Now, the most recent iteration of their concussion statement was following that Berlin conference in 2016. And if you haven't read this particular paper, then I would encourage you to do so, because it will give you an overall understanding of concussion and the basic principles surrounding recognition, assessment, and management. So what is sport-related concussion? This particular group defines sport-related concussion as a traumatic brain injury induced by biomechanical forces. And I think the important element there is that we're talking about a brain injury. One of the problems in sport and widely across sport is that often the condition is misdiagnosed. And if it's misdiagnosed, it tends to be underdiagnosed, thus underreported. And the true scale of the problem is probably not known in sport because it's underestimated. Now, in terms of the mechanism of injury for concussion, you need to consider the characteristic of those biomechanical forces, the direction, whether it's direct or indirect, and the speed at which that force is delivered. In concussion, the force can be transmitted to the brain either through a direct or indirect method. And typically, the direct method is induced by blunt trauma, and a typical example would be from head-to-head contact. An example of an indirect mechanism is when it's induced by an impulsive force transmitted to the head, say from shoulder-to-shoulder contact. So the important feature there, and the important thing to understand, is a direct blow to the head is not necessary for an individual to sustain a concussion. The forces that are applied to the brain and the head are equally not purely linear. There are rotational forces that are in play here too. And sometimes what appears to be a seemingly innocuous contact can actually lead to injury. So what about the pathophysiology? What's happening inside the brain as a result of that impact? Well, the shock is transmitted to the brain, and the outer surface of the brain collides with the inner surface of the skull. That's the point at which the primary brain injury is sustained. And typically, again, as described by the Concussion in Sport group, this results in rapid onset, short-lived, transient impairment of neurological function. And I'll come on to transient shortly. The acute clinical signs and symptoms from that blow to the head largely reflect a functional disturbance rather than a pathological structural injury. In other words, it's akin to maybe computer crashing. You're having problems with your computer. It generates some problems. You subsequently switch it off. You switch it back on. There's no problems with the inner workings of the computer, but there was just a temporary disturbance. And what happens is that the brain shearing takes place, which results in minute structural damage at neuronal level. The axons are stretched, there's neuronal death, and there's diffuse brain injury. But if you looked at the brain of this individual on standard neuroimaging, a CT scan, an MRI scan, you wouldn't see any specific abnormality. And often the recognition of the brain trauma that's been sustained is only visible post-mortem. The other thing you need to consider is that there's a possibility of secondary brain injury, which may also result due to a lack of oxygen and a failure or an inability for the brain to expel the CO2 or the carbon dioxide. So what's the typical clinical course for someone who sustained a concussion? The first thing I need to emphasize is that sports-related concussion does not require loss of consciousness. And in 90% of concussions occur without a temporary or transient loss of consciousness. So what we're saying is that only maybe 10% or so of players are actually unconscious following a blow to the head. Any obvious impairment that does occur to neurological function usually resolves spontaneously. So within a matter of minutes, the individuals appear well. You've also got the situation where you get what's known as acute latency, the time between the initial assault to the brain and a manifestation of the signs and or symptoms, which may take minutes, hours, or even days before a response is provoked. But as a practitioner who's working on the pitch and at the side of the pitch, you need to understand the potential to change rapidly and significantly after a lucid interval. So an individual may deteriorate very, very quickly in front of you. The other important thing to recognize is that concussion can be life-threatening. It can be fatal. Concussion is described as a mild traumatic brain injury, and that's based on a Glasgow coma scale of 15 to 13. But I would argue that this is a contradiction in terms for the simple reason, is any traumatic brain injury actually mild? 85% of the symptomatic cases typically follow a sequential course. In other words, most concussion cases resolve within 7 to 10 days. But some individuals have prolonged symptoms, headaches, memory issues, tiredness, which may last weeks, months, or persist for even longer. Now, what are the challenges of concussion? Well, for you as on-field practitioners, it can be difficult to detect. No two injuries are identical. There's a variability in the presentation and manifestation dependent on what part of the brain is injured. And it's a dynamic, evolving condition. The initial signs and symptoms can be very subtle, and the player may, in reality, appear normal. But trivial insults may be more problematical than they initially appear. There is a phenomenon known as talk and die. So individuals who appear to be well, who are lucid, who are talking to you, and some hours later, unfortunately, die. So you need to have clinical suspicion. What challenges have you experienced in managing a concussed player? I expect you've had experiences that are similar to some of the comments that I've made there. So in terms of concussion recognition, sports-related concussion is associated with a range of clinical signs and symptoms, and multiple domains are affected. These are physical, cognitive, emotional, and behavioral. Some signs are immediately obvious on the field of play and should be acknowledged and respected. What are the triggers that are going to alert you to suspect that a player has sustained a concussion. Now, you can see on the screen here, there are a number of red flags peppered on the screen. And that's just to raise the awareness that there are going to be signs and symptoms that present that merit immediate attention by an expert, an individual, a concussed player who has these red flag signs and symptoms will need to go to hospital and should be seen in an appropriate facility. In terms of the immediate signs on the field of play, so you try and visualize that a player has just sustained a concussion, a blow to his head. The first thing you will see is that maybe he's got no self-protective mechanism. He's described as floppy, and that's within milliseconds of the impact. And you will see this on in many of the cases when you watch, high-profile sports, on television. They may adopt what's known as tonic posturing, where they've got reflex flexion of the elbows and the arms towards their chest. They might demonstrate hypertonicity. They might have an impact seizure. They could be lying motionless on the ground. And in some cases, as we said, 10% of the cases may exhibit a loss of consciousness, which may be transient. And by transient, we mean that it's just a matter of seconds. Then we think about the player who's conscious. He may be holding his head. He may have a blank, vacant facial expression. And when he tries to get to his feet, have the motoring coordination, ataxia, a loss of balance, stumbling. He might be disorientated and confused, running in the wrong direction. He might exhibit abnormal behavior when you get to him. He might be combative. And equally, when you start asking him a number of questions, he might demonstrate amnesia. Then we think about the symptoms, and clearly symptoms can only be described if the player is conscious. Has he got neck pain? Has he got a severe headache? Has he got visual disturbance? All red flags that should alert you to the possibility of a significant concussion. And finally, one I missed off there, nausea. The individual may be feeling nauseous. So let's consider a number of scenarios, because in reality, you'll be confronted by a player who is in one of these three states. He may be clearly unconscious from the moment of impact and is unconscious when you get to him. There's the individual who exhibits that transient unconsciousness, which may have been witnessed, or there may be uncertainty about it. And then you've got the player who appears to be conscious from the moment of impact and throughout. So we need to consider how we're going to evaluate these players. It's worth remarking that in the World Cup in 2014, this was a statement that was released by FIFA, commenting on the fact that there were a number of incidents at the World Cup that showed that the role of team doctors needs to be reinforced to ensure the correct management of concussion cases in the heat of competition. I'd just like to extend that a little bit further. It's not just about the role, but it's understanding, recognising and managing acute concussion. And it's also about the training ground environment, where, let's be truthful, players spend most of their time, and where the medical support may be short or far short of what it is in a competition environment. So what about the on-field assessment? How are you going to assess these particular individuals? It is based on your clinical judgment, and your clinical judgment is about suspecting injury, or can you confirm there's been an actual injury? The key concept is rapid screening for suspected concussion. You're not expected to diagnose concussion on the field of play. Suspicion alone is enough, particularly cases with no loss of consciousness. And remember, 10% of players aren't unconscious. When you're on the field of play, you should follow a step-by-step procedure when you're evaluating that concussed player. And our particular model, the acronym, the abbreviation is MSCCC RABCDE, and I will elaborate on that in a few moments. But the priority is when you go onto the field of play, you must deal with the immediate and potential threats to life first. Do not prejudge the injury until you have fully assessed the player. Equally, do not be distracted by other more obvious but less serious injuries. And again, I will elaborate on that in a few moments. So you need to follow a structured, safe, systematic process when evaluating the athlete. And this particular process stands well for an athlete who's concussed, an athlete with a medical condition, or an athlete with any other injury. So it's a framework which you should use in evaluating all athletes or all injured players. So we need to think about the mechanism of injury. We need to think about safety and scene assessment. Then there are a number of issues, the 3 C's we describe them as, in terms of catastrophic hemorrhage, that's external bleeding, the cervical spine, and is the individual having a convulsion or an impact seizure, which is clearly relevant to the concussed player. The other elements that then follow on from that is we want to assess the player's level of responsiveness, their airway, their breathing, and their circulation, and equally their dysfunction. And it's at that point, if you've got a player who is conscious, you would be assessing their neurological status and their fitness to continue on the field of play. The final element of that process is everything else. And that typically involves examining the limbs, the peripheral appendages, and is usually considered to be the secondary survey. The important thing to recognise is that life conditions usually affect more than one parameter. And this particular process is a dynamic tool, something you should use for continual reassessment. So you should continue to go through this process until the player is in the care of other experts, until they're transferred to hospital. So from a concussion perspective, let's just look at the mechanism of injury. The mechanism of injury forms the basis of injury prediction. And typically in football or in sport, that's direct blunt trauma to the head-to-head contact through an opponent or a teammate, an elbow to the head, sometimes described as an elbow kick, ball to head, boot to head, goalpost contact. These are all elements that can result in a concussion. But what is often missed and sometimes missed is that subsequent impact when the player falls to the ground, unable to protect themselves, and they have a subsequent impact with the ground and their head, thus sustaining 2 acute concussions in rapid succession. Now, in terms of your approach to the player and going onto the field of play, you may have reservations and you may hesitate. But let me assure you that FIFA, again in 2015, said there are 2 situations where the team doctor and medic can run directly onto the pitch without being asked. And those 2 particular instances are a suspicion of cardiac arrest or a head injury, such as a concussion. So it illustrates and emphasizes that you need to get onto that pitch as quickly as you possibly can. Now, in terms of safety, you need to consider that what's described as the 1, 2, 3 of safety. So you need to protect yourself, you need to protect other players who aren't at this point injured, and then subsequently the casualty. So from your perspective, it's a scene safety assessment, a visual scan. Is it safe to approach the field of play or enter the field of play and approach the player? You do not want to become a casualty by running directly onto the pitch and then making contact with another player who then also becomes a casualty. But when you get to the field of play, how long have you got? Again, following that World Cup in 2014, FIFA were very clear and made this statement that if you suspect a concussion, the referee will have the ability to stop the game for 3 minutes, allowing you to complete an on-pitch assessment and decide if the player is concussed or you suspect concussion. What I will say is that often evaluating a player can take longer than 3 minutes. And you shouldn't be intimidated or hurried by referees into conducting an inadequate or incomplete assessment. or moving the player until you are satisfied. Remember who's got the duty of care responsibility. It's squarely on your shoulders. And I know that there are currently in a number of leagues in Europe where concussion substitutes are being trialled. You know, if a player is concussed, he's removed from the field of play, and another player can be brought onto the field of play. But you still have to make a clinical decision about that one individual. I said there were a number of small C's. Catastrophic bleeding is one of them. Now, catastrophic bleeding is described as arrestable, compressible arterial bleeding. So the blood is pumping from the casualty. Blood will be on the floor. It's rare in sport, but it's got the potential to kill quickly. And management over this takes precedent over any suspected spinal injury or even the player's airway. But a scalp wound or a nasal injury, which is bleeding heavily, is not catastrophic bleeding. And this is where I want to make the important point that you shouldn't be distracted from addressing a potential concussion. Consider the force required to fracture a nose and the implications on the brain and what's going on inside the skull. Now, in terms of the cervical spine, if there's any supraclavicular trauma, that's trauma above the level of the clavicles, spinal pathology should always be considered. And thus, the spine should initially be stabilized manually until that issue has been cleared. And you'd stabilize the neck, the head and neck, in the position in which it is found, irrespective of whether the player is conscious or unconscious. So suspect spinal injury until proven otherwise if the player is unconscious, and if they are conscious, if they're complaining of focal cervical pain or paresthesia in the arms and legs. And in that particular instance, you'd need to apply full spinal precautions consistent with current spinal management protocols. Now, a convulsion or an impact seizure is also a possibility from someone who's sustained a blow to the head. These are involuntary clonic movements. They're asymmetrical, irregular, rhythmic jerking of the torso or limbs. Again, it's a red flag. It's something that merits the individual going to hospital and being seen by appropriate clinicians. It's often very dramatic and alarming. It's something that can be quite scary for any one individual. But the reassuring element is that it's usually inconsequential, it's usually self-limiting, and most instances of seizure resolve spontaneously. But in terms of your initial management, try and stay calm. Don't restrain the player. You do not want to be pinning them down by their head or neck, because you might generate cervical spine injury yourself by pinning them down, and that being an axis for their particular movements. Protect the head from further harm. Open and maintain the airway at the earliest opportunity, and then administer oxygen. Now, what about their level of response, the level of responsiveness of the player? Typically on the field of play, an AVPU scale is used. The AVPU scale essentially relates to a number of elements to describe the status of that injured player. Is he alert? Is he conscious? Can he talk spontaneously, clearly, and sensibly? If that's the case, he's described as being fully alert. However, if he's not fully alert, does he respond to your verbal commands? You're advised to use the player name, ask in a loud voice, can you hear me? Give him some commands, instruct him to open his eyes, and see whether or not they respond to your voice. The next element is a physical stimulus. If he's not responding to your voice, initiate a physical stimulus. Pat the player. Do they respond? If you're maintaining manual stabilization at this point, you can equally apply that physical stimulus by putting supraorbital pressure over one or both of the eyes. And then if they're unresponsive, the player is described as unconscious. And the worrying, or the thing that should be of concern, is the loss of the gag reflex at this point. They're unable to protect themselves. They're unable to protect their airway. They're unable to protect against the aspiration of any fluids. And that period of unconsciousness, as I said before, may be transient. The bottom line is, in terms of response, any player who's not fully alert, is unconscious, or regains consciousness after that transient period of unconsciousness, they must be removed from the field of play once they've been managed and not allowed to return to activity on the same day. But another element you've got to consider is what we describe as a manageable position. Is the player in a position in which they're capable of being fully controlled, assessed, and able to receive any necessary treatment without the requirement to move them into another position? Is the player conscious or unconscious? Is the player prone or supine? Can you absolutely confirm that the airway is clear, that the airway is open, that they're breathing normally? Because if you can't, you're going to have to move this player. Do you need to move them into a manageable position? How will you move them? How will you control the cervical spine at the same point? So your primary assessment and management on the field of play, and we're now thinking about the unconscious individual, is their airway patent? Is it clear and open? Because you need to establish and maintain that airway. Now, what needs to be addressed here, needs to be mentioned, and you can see by the two illustrations on the screen, that on the left-hand side, as you look at the screen, the airway is occluded, the tongue has fallen back. But by using a manual maneuver, the airway can be opened and the tongue is moved forward. You can't swallow your tongue. Yes, it becomes an obstruction, but by applying a manual maneuver, you can remove that obstruction. But players putting their fingers into an injured teammate's mouth is highly inappropriate. You must educate your players and staff. In the image, we're demonstrating head tilt, chin lift. That wouldn't be appropriate for spinal injury. In that particular instance, you'd want to use a jaw thrust maneuver. So once the airway's opened, what's the status of their breathing? Is assisted ventilation required via a bag valve mask? Can oxygen be administered? It should be administered. We've already talked about and mentioned, the secondary brain injury due to a lack of oxygen. And then the third element you need to consider in your assessment is circulation and hemorrhage control. Now, in terms of the concussion, they may well be experiencing, there may well be epidural, subdural, or intracerebral bleeding. But there's little you can do about that. They need to get to hospital. The important thing is that you do the basics well and you call for the emergency medical service and evacuate the player safely from the field of play with the appropriate resources. Now, for the player who is conscious, his airway is patent, he's breathing normally, he's got a circulation, his brain is being perfused, you then need to assess his neurological dysfunction. And at this point, it's initial assessment of the signs and symptoms, his cognitive function, that's his memory, pupils, balance, and coordination. And the Concussion in Sport group have devised this particular tool, which you're advised to refer to, which is known as a concussion recognition tool. Now, it's an aid to on-field assessment and rapid screening of concussion, but it supports your decision-making. It's not the standalone method to simply diagnose concussion. So you're using that tool in conjunction with all the other elements of your assessment. Pouring water over a player's head and neck does not constitute reasonable practice at this point, and it shouldn't be part of the management of that casualty. So what about their memory? What questions are typically asked? Well, it's what's known as Maddox questions, and they typically ask, what venue are you at today? Which half is it now? Who scored in the last game? Who did we play in the last game? Did we win our previous game? Now, they need to answer all those questions correctly and appropriately. You obviously need to know the answers too. But if they're unable to answer the questions, or there is any confusion or slurring of speech, suspect concussion. Would your player know the answers even if they weren't concussed? And in terms of the pupils, the eyes, they're considered the windows of the brain. And typically, you evaluate whether the pupils are equal and round, regular in size, and light reactive. Being light reactive, an indication that the brain is being perfused. What are your pupils like when they're healthy? Are there any abnormal presentations even when they are healthy? You would need to know that. You need to check the visual acuity and check for any visual disturbance. Again, blurred or double vision is a red flag. What needs to be said is that pupil dilation, sometimes described as a blown pupil, is a late and very ominous sign, and not something that you're likely to see on the pitch. The other element you need to assess on the field of play is their visual field. If they've got what's described as visual spatial dysfunction, this hampers the player's ability to process the visual information about where other objects are in space. So that's the movement of the other players around them and equally the ball. So you need to check their hemiglobal and global vision with the head and eyes facing forward. And if there are any concerns here in terms of that global vision or hemiglobal vision, you can see that it's a red flag. The NFL describe balance issues as gross or sustained vertical instability, i.e. stumbling or falling to the ground when trying to stand. Again, it's a red flag. Now, if you want the safest way to move a player from the ground into the upright position is follow this particular process. If he's lying on the ground, get him to roll over onto his front, ask him to go onto all fours, get him into upright kneeling, then single leg kneeling, and then stand him fully upright. And if there are any problems in terms of his balance as he goes through those various stages, it's a very simple process to return the individual back down to the ground. Now, in terms of your return to play criteria, addressing all those elements that we've just considered, the individual needs to be fully alert and orientated, not confused, and no memory loss. So you've checked all these particular elements. They've no neck pain or tenderness. They've full pain-free neck range of motion and full head control, which suggests you've evaluated their spine and you've cleared that spine. They've no neurological features in their limbs, whether sensory or motor. They've no headache. They've full normal vision. The visual acuity and visual field has been confirmed as appropriate. They've got normal balance and coordination. They're not vomiting, which can be a sign that an individual is concussed, not typically seen on the field, but may, in the rare instance, if an individual is left on for a period of time, he may start vomiting several minutes later. But ultimately, the individual needs to be fully functioned. The important thing is that if you're in any doubt, you should not be clearing the individual to return to sport. Again, FIFA said the referee will only allow the injured player to continue playing with your authorization. You have the final decision. But you must document your clinical reasoning and rationale for returning a player to the field of play. You may need to defend that position at a later point. Now, in terms of suspected concussion, again, the concussion in sport group are very, very clear. If there are any signs and symptoms in any of the clinical domains, concussion should be suspected. And if so, the player should be removed immediately and safely from the sporting environment and should not return to activity until he's been fully assessed. The Premier League rule takes that one step further, that they should not be allowed to resume playing or training on that same day. You're strongly advised, as I said, when in doubt, err on the side of caution at all times and seek assistance from the experts in challenging clinical situations. In the Premier League here in England, they have a match day medical coordinator, sometimes described as a tunnel doctor. And each club is responsible for appointing one medical coordinator. And he's there to assist with the identification and assessment of concussive injuries, whether through the use of pitchside technology, which again is available at elite level, or through other forms. The touchline video analysis can be used to help establish the mechanism of injury, the potential severity, and contribute to the overall assessment of the player and support return to play decisions. However, that video technology could also be used in the event of a poor outcome. It may be used as indisputable evidence to prove that a player was concussed and should not have been returned to play. If you do return a player back to activity, ensure you continue to observe them, monitor for a deterioration in performance, and withdraw them immediately if you've any concern. And if they sustain a second blow to the head, no matter how minor you consider that blow to be, again, they should be withdrawn from activity. And following the game, consider the changing room and shower areas. Don't let them be the last ones out. What are the dangers of returning an individual to play? Well, you want to avoid exacerbating or worsening an initial injury. Concussed players have an increased susceptibility to a subsequent concussion. And continuing to play, having not recovered from the first assault, may result in a more serious brain injury than they initially had. There's a phenomenon known as second impact syndrome, where the brain swells rapidly after a second concussion before the symptoms from the initial concussion have subsided. It's potentially fatal, particularly, they say, amongst young players whose frontal lobes are still developing and are doing so up until the age of 21 years of age plus. Something to think about yourselves. Have you got a medical emergency action plan for dealing with two of your players who are concussed at the same time as a result of a collision? Have you got a plan for dealing with a concussed player who may have a spinal injury? Have you got a plan for a concussed player who deteriorates quickly in the dressing room, on the team bus, or in the hotel? In terms of your clinical decision making, as a medical practitioner, you're expected to act in the best interests of the player in a way that upholds the principle of duty of care and the proper administration of medical care, with professional autonomy, with integrity, and in a way that upholds public trust and confidence in your profession and in the services provided by you. The key being that you ensure you make fair, consistent, and proportionate decisions. You also need to be an advocate for the player, protect them from themselves. When a player sustained a concussion, they're unable to think sufficiently and clearly to make an accurate assessment of their own health. Duty of care. Before the achievements of a club, the health, safety, and welfare of the players must prevail above all other considerations. As medics, you must not be putting sporting outcomes before professional obligations. The dominant relationship or connection is between you and the player, not the club, and that's where your primary responsibility lies. You've got a duty to do no further harm, a responsibility to identify the concussion and take decisive action. Your individual management and return to play decisions are a clinical judgment, but must be in accordance with the consistent, contemporaneous guidelines, doing what the experts are telling you, doing what the Concussion in Sport group are advising you to do. So would you be deemed to be negligent? Well, there is a test that's often applied in a legal environment or legal circles, and the question would be, what would a prudent, reasonable person with an equivalent level of knowledge and training have done in the same circumstance? So you're being compared to your peers. To avoid liability, you need to have acted in a way which reaches and is consistent with the standard and a way in which a responsible body of medical opinion would advise in handling on-field suspected concussions. And also a standard set by the competition guidelines, given that this should be informed by research and medical opinion. It will acknowledge and take into account the environment in which you're in. Clearly, trying to manage a concussed athlete in an on-field setting is markedly different from managing a concussed athlete in a formal clinical setting in a hospital environment. In terms of recording an incident, due to the nature of concussion and that possibility of a rapid deterioration in their condition, it's critically important that you document the incident as soon as you possibly can, and that may well be on the team bus. Because what you don't want to be seen to be doing is retrospectively fabricating a report on a player's status. It will not be viewed favourably if you try and match their condition some way down the line. So protect yourself. If your clinical guidance has been ignored by an injured player or overruled by a coach in search of that sporting outcome, make sure you document it. If it's not written down, it didn't happen. Another phrase that's often used, poor records, poor case. No records, no case. And a final point in terms of your own protection is professional indemnity. Have you got sufficient indemnity to cover your practice? You will be accountable for your actions, and you will be liable legally should a player suffer personal injury as a result of your mismanagement. So to protect yourself, have sufficient medical indemnity. A malpractice and negligence claim against you and any award for damages will be limited by your ability to pay out, which will depend on the precise scope of your insurance cover. But you've got a professional responsibility to limit practice to areas of established and maintained competence. Simply being a qualified medic is insufficient to work in sports environments. You need to be specifically educated, trained, and competent in pre-hospital emergency care. And your professional indemnity insurance will be invalidated if you operate outside your scope of clinical practice and training. And you need to operate within your scope of practice, but if your conduct and practice is deemed to be inappropriate and outside the accepted protocols, again, your professional indemnity insurance will be invalidated. Do you have an adequate level of indemnity provision to protect yourself against such liability? So what I want to do, those of you who've been observant will have seen that throughout the presentation, I've been listing a number of, or highlighting a number of important points. And I'll describe these as your starting 11. So 11 for concussion. The important thing to understand is it does not require a direct blow to the head. It does not require a loss of consciousness. There's that potential to change dramatically. Don't be distracted by superficial injury. Suspicion alone is sufficient to make a decision to remove a player from the field of play. Ensure you have a medical emergency action plan and a care pathway for your concussed player. Protect the player, be their advocate. Don't let sporting outcomes influence your return to play decision. Again, document the incident as soon as you possibly can. Ensure you have sufficient professional indemnity. And a final and very important point, and something which is very being discussed largely in many sporting environments now. It's education, education, education. Education of yourself, the player, and the coaches. And I hope this presentation has gone some way to increasing your understanding and knowledge of concussion. The final point, in terms of the individual who needs to be at the side of the pitch or should be at the side of the pitch, it needs to be the right person with the right knowledge, skills, and understanding, and the right equipment in the right place at the right time to ensure the right outcome. Right? Right. Thank you very much for listening.